afternoon, everyone, and welcome to the latest installment of our virtual programming series. I'm Greg Mencken, the Executive Director of the Adam Smith Society, and I'd like to wish all of you health and safety during these difficult times. The mission of the Adam Smith Society to promote discussion around the benefits of free enterprise remains as important as ever. We'll continue to offer opportunities to hear from leading experts online, and we look forward to a time when we can all get together in person once again. So thanks for joining us today to get in your weekly Smith-Sock fix. If you're not already a member of the Adam Smith Society and you'd like to learn more, please visit us at adamsmithsociety.com. Joining us today is health tech entrepreneur Sebastian Seiguer for a conversation about the implications of coronavirus for telehealth delivery. Sebastian is CEO and co-founder of Emocha Health. He is an expert in newly emerging health technologies, health data, and health policy. He is a scientific reviewer for the NIH Small Business Innovation Research Program and a co-principal investigator on 3 NIH-funded medication adherence trials. He earned his law degree from Columbia University and an MBA in healthcare and finance from Johns Hopkins. So he's kind of one of the family in that regard as far as Adam Smith Society goes. Sebastian and I will have a conversation for about 15 to 20 minutes, after which point we'll open to audience Q&A. Please note this conference is being recorded. You may ask your questions in the question box in your GoToWebinar controls. Questions will be read aloud to the group by my colleague, Dean Ball. Please keep your questions and comments brief and state your full name and chapter affiliation to ask a question. We'll get to as many as possible. And just please note for everybody, there might be a small delay in Sebastian's audio and video as he's using his phone on the audio side. So please bear with us if there's any issues in that regard. So with that, we'd love to get going. And Sebastian, thank you so much for joining us today.
Thank you very much for having me, Greg.
So Sebastian, I'd like to start off by asking kind of a big picture question. Telehealth, telemedicine, mobile health. Could you just kind of frame all that for us? What is telehealth versus telemedicine, for instance? What does that mean?
Right. So in general, you've got 2 things to think about, which would be, on the one side, what do people use as common terminology? And on the other side, what's the regulatory framework? So telehealth generally refers to the ability to have a live connection with somebody on video that is treated equivalently as a visit to that practitioner, to that clinician. Mm-hmm. Telemedicine is shuttling, for example, it's sending a radiology image from one place to the other, so sending those files and having somebody else review that remotely. And then there's this entire field now, which has been cut out in the regulation, that's called remote patient monitoring. It's a bit of a hybrid. It's taking some synchronous, some asynchronous, meaning recordings or images or other data, and then reviewing it in another place. So those 3 areas have been a legal mess in regulation for quite some time.
Okay, and you mentioned the asynchronous side of things, and I think that relates more specifically to your business. So Sebastian, tell us about Emocha. What does it do? Tell us what kinds of patients and customers do you have, both in terms of before COVID and how that might have changed since COVID.
Sure. So yes, we are what's considered asynchronous. Emocha is a video platform for making sure patients and helping patients take their medication. It works by the patient using an app to video record themselves at every dose taking medication. And on the other end, the provider or our team will review that, engage with the patient through a chat, and try to get them up to 90-some% medication adherence, meaning taking of medication. We fit into remote patient monitoring because that's what we do. However, because there's this video component, we're this stepchild of telehealth, where because non-live asynchronous video is a bit of a rarity, but it's recently, I think last year, recognized by CMS, so Medicaid and Medicare, as a form of actually its own form. It's not even telehealth. It's something called remote telecommunications. So before COVID, we were focused on medication adherence. We served public health departments. In the last 2 years, we started serving hospital patients and health insurance company members. That's pre-COVID. The world changed pretty radically about 10 weeks ago for our business, in that We'd always had this one side installation where we were monitoring healthcare workers at the biocontainment unit at Johns Hopkins since the Ebola days. So if anybody walked into that unit, they'd get emocha, and they would do a check-in every day for 14 days. Well, Hopkins 12 weeks ago asked us to put that in every hospital. We thought they couldn't handle the software by themselves, so we offered them to do the software for all employees, but also our team to review the submissions coming in and escalate the concerning ones back to the hospital. So, we implemented 6 hospitals at Hopkins, then 4 other local ones, and now about 5 others that are all over the country. But that would be the smallest piece of what's happened. All of our existing customer base then really ramped up their use of our software. And now we are getting an endless stream of employers who are trying to see if remote monitoring of their employees will help them get back to work.
I see. And so are you going through this process now of adjusting your business to meet new market needs that you're seeing?
Oh, absolutely. It's really interesting. In September, October, I had a lot of pressure internally from the team to kill that biocontainment unit project because it was just this very tiny little customer, and I just really wanted to keep this option open, but I recognized it was, one request from that customer slows us down for the other things we're doing. So, but yeah, when the coronavirus became, and remember, we started in infectious disease, right? In public health departments. So we have really pole position and real insight into this market. So we did hear our advisors telling us in January, look, this is coming. This is going to be a big issue. So in early February, we pulled the trigger and just said, all right, let's drop a lot of things we're doing and let's go, full in on this. And we were able to turn on a dime and alter our entire business model, not just from adherence monitoring, but to symptoms and temperature monitoring. So yeah, now we're faced with another pivot, which is employers, and we have to make the decision: is that a market we want to serve? What's that product look like? It's a little different than monitoring healthcare workers.
Mm-hmm. Mm-hmm. Okay, and obviously the healthcare industry at large is probably one of the most heavily regulated industries that exist, and so since the crisis has hit, we've seen a relaxation of a number of telehealth regulations. For instance, the federal government eased restrictions on the use of mobile devices for virtual visits. Medicare and Medicaid are now paying the same rates for virtual versus in-person visits. Tell us about how these regulatory changes have directly impacted your business and the telemedicine telehealth industry at large.
Right. Well, a lot of regulations that should have been relaxed a long time ago, which were just like piecemeal, loosened. Really, those regulations were to the detriment of patient care, because there is no reason why a very mundane question can't be answered over the phone in some cases. Now, there are other cases where it's really important to go see a doctor or a nurse. But yeah, the loosening of the regulations had multiple effects for us. There's a reimbursement pathway, which is extremely clear right now. There is a tolerance for what we do. There is a desensitization that what we do is somehow, in some states, not allowed, right? You could not shuttle asynchronous imagery and then get paid for it about 6-8 weeks ago in some states, and now it is generally allowed. So I think that the loosening has created massive opportunities for patient care to become more patient-centric. And when I use that word, patient-centric, in the past that was a term that was like loosely battered around. The patient is in their home right now, and they're receiving care via telehealth in some format. That is the purest form of what the term patient-centric actually means. So we're seeing a really interesting dynamic now.
Okay. What do you think that regulators could do further to further improve the care model that we have, to further support businesses in their efforts to innovate going forward?
The current regulatory framework is a bit of a disaster, and it's a mixed model that is different in many different states. In the past, I would have given you very specific regulations that should go away because that's the way that the system operates, one little regulation at a time. Mm-hmm. So I don't want to paint the picture of telehealth as being the end-all be-all, because we right now have the highest mortality rate we probably ever had. A lot of people have died, and it's not clear why. So is it because of COVID? Is it because people didn't access care because of COVID? What's happening? And we don't really know, and we'll know soon. Mm-hmm. But and at the same time, hospitals are really losing and bleeding money. So the whole, it's a very complex situation. It's not clear that there's any one solution, but the way hospitals get paid is going to have to change. We know that, because otherwise they're going to bleed. Mm-hmm. And we don't want that. On the other hand, look, let business take care of this. Business people think in very creative ways when they're under pressure, when the threat is that your business is going to be gone and you're going to be on the street, when you're faced with a decision to have to fire everybody because of something like this. People get really creative. And you're not, that is part of human nature. Let that instinct take over now, and let's create a new economy based on our current situation.
Mm-hmm, mm-hmm. Now, as we talk about this new evolving landscape for healthcare, telehealth visits have surged by 50% in March. By some measures, there'll be 1 billion telehealth interactions this year alone. Do you think this is a blip, just a response to the current crisis? Do you think that we're seeing a long-term change here? So is this a short-term thing, or do you see kind of a permanence emerging here?
Yeah, so it's permanent. It's not a blanket panacea, like I said before. So think about it this way. You have multiple ways that you can communicate with another human being right now. We can send a text. We can use this video conference. We can have a phone call. We, as consumers, switch between these modalities quite fluidly without thinking very hard. But to have a visit with a doctor, or a nurse, that's some big deal right now, right? When we practice that several times, and the privacy issues it becomes clear that the privacy issues aren't really a problem for patients, or that you really actually can get care, then as consumers, we will demand that those options be available. In the same way, when those visits are unsatisfying, we'll demand to go and see somebody in person. So once there's a taste of this, it'll just become care. It's not telehealth. It's not asynchronous video, remote patient monitoring. It's none of that. It's just, this is how, as a consumer, I want to access my care.
Mm-hmm. And beyond the healthcare impacts, which are obvious, there's obviously tremendously huge economic impacts. And so the timeline of the crisis has been first a healthcare crisis itself, and now as states are looking to reopen, we're trying to get the economy back going. Obviously, we're trying to get people back to work and back in the workplace itself. And so as you're looking at that latest phase of the crisis, how are you thinking about that? And how can telehealth, telemedicine emerge as a more accessible form of healthcare for workers in general, just to get them back into the workplace?
Yeah, the return to work scenario is pretty complex in some ways. You are, as a business, you've just become a bit of a public health department. You're responsible for a safe work environment. The liability concerns are unclear right now, but fact of the matter is, to have a safe work environment, you need to understand if certain employees are symptomatic on that day. The complexity and the need for what I'll advocate for remote patient monitoring is, if somebody comes into work today and they do not have a fever, but they had one yesterday, they should not be at work. how can you know that? And so the ability to manage a population of employees and to understand who is sick today, but who was sick yesterday and the day before, that's complicated. In addition to that, there are certain people who are at very high risk with a disease like COVID. So people with pre-existing conditions, older people, there's a real need to in healthcare in general, to understand what the criteria are for them based on their work environment and when they should return. So there's a lot of variables here. Telehealth will continue to be an easy route to manage some of these issues. So, for example, what we're doing is symptom screening remotely so that you don't have to get screened at the door at your workplace. You don't have to wait in line in the rain for somebody to check the temperature. You can do it on your own at home, and your employer can see 7 days of previous data so that they know whether you were sick a few days ago and pose a risk to others. So yeah, business can solve this problem.
Okay. And so what do you think some of the other opportunities out there for companies like yours or others in the space? What are some of the other opportunities and challenges that you think exist for other companies?
Yeah, the challenges are somewhat unforeseen in that the economy has so radically changed, and we don't know how consumers are going to be reacting, and supply chains, et cetera. But fact of the matter is that this is a new economy right now. There are different things that are needed. There are different things people want to purchase based on just the situation. So this is the time where entrepreneurs can really, really make a big impact and secure opportunities to meet these demands, which before didn't exist. Because they didn't exist before, they are currently unmet. So I would say that the economy is forming. It's a moving target. There's a lot of opportunity, a lot.
And finally, to wrap up here before we go into Q&A from our audience online, how do you see the role of free enterprise here? How will free enterprise continue to drive healthcare innovations to meet this present challenge and for decades to come?
Well, we had a certain landscape 60 days ago. We had ways to treat patients. I'll talk about healthcare now. We had ways to treat patients who had HIV or addiction or asthma. We were working with a group of patients with asthma. We haven't heard from their providers. Those providers are not reaching out to us to tell us how those patients are doing. Patients who previously accessed healthcare in a certain way are not. Those patients are in serious jeopardy right now, and the market can react to those needs. So as an example, methadone treatment for patients with addiction. It requires patients to go into a clinic to get methadone. It's been highly controversial for many years. The DEA has just relaxed the take-home requirement. Patients can now take methadone home. A lot of those patients really benefited from the structures and the counseling. We're going to have overdoses like we've never seen before. We're going to have reinfection. We're going to have HIV infections like we haven't seen in a while in outbreaks in many places. Patients with asthma are going to end up either, hopefully not, but potentially dying at home or, ending up in the emergency room. Our chronic disease population was a problem before. It's a bigger problem now. Healthcare as a area where business can step in to fix some of the problems that the current landscape has created. There's so much need right now. And it's not a need just for providers and nurses, docs. It's a need for business to solve what is in essence, in many ways, a communications problem.
Got it. And I think you bring up a really important point there, which is everyone's been so focused on COVID and COVID patients. There are still millions of other people with other conditions and other healthcare needs that still exist, and we can't forget about those folks as well. So,
well, yeah, and that'll be the bigger story here, I believe, Greg. So if you just look up the mortality all-cause mortality right now, it's through the roof all over the place, and that's not COVID. COVID is certainly a big piece of it, but COVID-related, meaning I can't access healthcare right now. I'm going to die at home. This is happening, and this will be the bigger issue.
Okay. So with that, let's open it up to Q&A from our audience. Questions will be read aloud from my colleague, Dean Ball. So Dean, do you have a first question, please?
Yes, we do. Michael Putnam asks, one of the challenges with patient adherence and patient management historically has been that it is very labor intensive and hard to scale up. Could you discuss to what extent you see telehealth being able to address that problem and what types of companies you think are well positioned?
Okay, that's a great question. Adherence is very multifaceted. You could break down the problems into three areas. Access to meds, so getting a prescription or being able to finance it. Second is problems with medication. And the third is behavior change. We believe that the only solution to medication adherence is an observation or a medication management appointment at highly frequent intervals. That is not possible in person. It was not possible before COVID. It's certainly not possible now. We believe that our method is very good at securing the behavioral piece and catching medication problems. Certainly the ability of a patient to fire up a live telehealth appointment with a doctor to ask about medication management issues or a pharmacist, that is it is a fix for a huge issue. So if there's a will to solve adherence as a problem, there are certainly tools out there to make it a solvable problem.
Philip Holstead from our Wharton chapter asks, how do you think the long-term increase in telehealth adoption will vary by medical specialty? Which will keep the change the most versus which will revert back to largely in person?
Yeah, I'm not being a doc, I can't really say entirely, or a physical therapist or a nurse. But what I can say is that there are many routine things which just require a quick answer, and those are certainly helpful. I think, for example, pediatrics, like sometimes you just have a quick question and you have to bring your kid in somewhere. That's a quick visit on video. On the other hand, something like physical therapy is very challenging remotely. Think of that as like a sport. Does that, anything with technique, it gets really tricky to manage it entirely remotely. So, people don't get the same experience that, on video that they do in person. Maybe think about it in the same way that you would, we'd love to be in a big conference room right now and then, shake hands afterwards and exchange business cards. There are different formats for everything, and common sense dictates that a lot of things can be solved by telehealth, and a lot of things really should be given a dedicated in-person meeting where the person can put their hands on you if they need to.
Patrick Savage from our University of Pittsburgh chapter asks, long-tenured healthcare professionals have traditionally been resistant to adopting new technology in their diagnoses. With the COVID pandemic, have you noticed an increase in adoption of telemedicine from previously resistant physicians, creating more of an economic opportunity for telehealth companies?
Yeah, so let's define technology. So technology can sometimes include new therapeutics, drugs, which help patients. And I don't think that clinicians have been very resistant to those type of novelties. What they've resisted has been becoming data entry clerks, right? So, my wife's an HIV doc. She sees 20 patients in a day, sometimes has to come home and type up 20 notes. They each take her about 20 minutes, unless she wants to copy paste text, which is standardized, and she won't do that. So we've asked clinicians to become essentially data entry clerks for the last 10 years. Why did we do that? We did that because the Affordable Care Act and previous meaningful use standards required electronic medical records to be implemented by force of law and regulation as opposed to pure business need. So, of course, clinicians are really resistant when it takes them away from dealing with the patient. So that leads us to the ability to add people who are not providers, not licensed, into the healthcare workforce to assist them. So if our regulation can evolve to allow more of these type of workers, healthcare workers, non-licensed, to help out, then we can get healthcare to be more affordable. I don't think it's the clinician resistance. I just think it's the reason why it's been, put into the economy, which is regulation, that has dictated the way clinicians adopt. If it's law to do a medical record, you don't care whether it's user-friendly. You just have to have one. Epic, which is an amazing business, I really admire that business. No venture capital, bootstrap business, incredible. That is so not user-friendly, and it never had to be, because you have to buy it. You have to buy an EMR. It's the law. So that's my answer. Hope it's helpful. It's a good question.
Yeah, so Sebastian, following up on that question, the question was about clinicians. Can you talk about how healthcare organizations at large have responded to this transformation and trend now toward telemedicine, telehealth?
Yeah, so for patients who can access telehealth, then the clinician can now do that. Almost every electronic medical record system would have some telehealth capacity. So they've allowed it now, and for patients who can access it, that's a good thing. Unfortunately, the billion or so visits is going to be dwarfed by the previous in-person visits, so nobody's making money. Hospitals are losing a ton of money. You're talking about, in large health systems, upwards of $1 billion for the year for 2020. It's going to happen. So clinicians want to see their patients. They'll definitely do telehealth right now. They're not unwilling. They want to see them, but they don't want to see them in person because that's risky, right? So I think that clinicians are certainly very, very willing right now to try it if their patients can do it. Did I answer your question?
More broadly about healthcare organizations. Healthcare organizations as a whole, larger, provider systems, hospital systems, things like that.
Yeah. Okay. Oh yeah. So they need to bill. Right? So telehealth, you can bill for it now. So yeah, they're going to bill for it if they can. Otherwise, their revenue's gone. I'm in Maryland. Maryland is the one state that has what's called global revenue. They just give the hospital the revenue at the start of the year. Doesn't matter what they bill. It does, but not really. They don't get directly paid. Hospitals in Maryland are in a lot of trouble. That's the value-based care model, but taken to a very, very big extreme. And the Maryland hospitals they have a guaranteed revenue, but at the same time, they can't adjust their model as rapidly.
Elena Gambon from our Berkeley Haas School of Business chapter asks, do you have any recommendations for safety net hospitals that are resource constrained in investing in and implementing telemedicine solutions?
Telemedicine is not expensive to implement. Many of the large telehealth providers are HIPAA compliant. I think that, do they have the equipment for it? I think they would. The safety net hospitals would. A lot of them would have equipment for it. I guess we do deal with a couple of safety net type providers if they have billing capacity, right? So a lot of these entities get federal funding or state funding and don't have sophisticated billing capacity. That can be a barrier. But I would say that it's all billable now, and the regulations have been relaxed. So I would imagine, but I'm not an administrator of a hospital, so I'm not entirely sure how the safety net business model would work. Certainly Medicare, and by the way, I should say Medicaid is state by state. So actually, safety net hospitals deal with a lot of Medicaid. I would say that is quite the challenge right now because it's not clear that Medicaid billing and regulation has been loosened. That's a state-by-state decision, and Medicaid moves very slow in most states. The CMS at the federal level, so Medicare, has been radical in the last 2 years in a great way. Deregulation has been amazing. Medicaid takes years to follow, and I'm not sure in which states have been fastest here.
Everett Lawsey from our Boston Professional chapter asks, in what ways are pharma manufacturers engaging with Emocha? How do you think that might change given COVID-19?
Well, we haven't had a lot of direct pharma contact in general. We have a different approach than pharma really appreciates, I'd say, in that we care about whether patients take every dose of medication. Pharmaceuticals are more, they can't drill down to that level of detail, and they're more concerned about whether their product is being used, and they measure that through refill. We are involved in several clinical trials where we are the technology that helps secure adherence in the trial. But other than that, and we are actually going to be involved in a fairly interesting Hopkins-run study for a potential treatment for COVID that launches in 2 weeks.
Jonatas Farias from our University of Pittsburgh chapter asks, I ask if Sebastian sees Omocha as a service that should be seen as a more efficient differentiated product, or is it a way to provide care in a cheaper way? So do you view it as a differentiated, more efficient product than what it currently exists, or just a cheaper one?
For our public health customers, it's the former. It's a more efficient way to deliver a standard of care that's been around for 40 years. So we're about a quarter of the price of seeing somebody in person every single day for medication adherence. For the rest of the market, we're a service that does not exist right now in a niche that is non-existent because it's considered impossible to change behavior at scale. So in that case, we are a unique and novel approach, and let's say an efficient way to reduce the overall cost profile of a highly expensive patient.
Anthony Perry, also from our University of Pittsburgh chapter, asks, how do you see telehealth influencing the patient/insurance/hospital relationship regarding in and out of network service?
That's a great question. I'm not sure if all of you know this, but the large telehealth companies like American Well, they have their own bench of doctors and nurses. And sometimes when you access the University of Pittsburgh's medical center, you're not accessing, UPMC is probably a bad example because they're very, very good at technology, but let's say any other system. You might not access that system's doc, you might get an American Well doc. So I think that there's a chance that a lot of providers are going to get cut out because, if you're at home and can access a doctor, well, that doctor could be anywhere too, right? So I think we're going to see a decentralization of care for certain types of care. So, it's not going to be relevant that the doc is at Hopkins necessarily, but if Hopkins contracted them, they could be sitting in Alaska, as long as they have a Maryland license, of course. But so I think that was a very good question. And I think that we're going to see a radical change in geography in terms of, and actually different business models in terms of where is that provider? Are they actually in a hospital or not? They don't have to be now.
Ling Ma has a question specifically about public health departments, and she's from our UNC chapter. What are the pain points that apply specifically to public health departments, and how do your products solve them?
Well, so Mecklenburg County in North Carolina is our customer. For 40 years, public health departments go out to patients and make sure they take their medication for highly infectious diseases. When there's an outbreak, public health departments are also responsible for the care of that, like a patient with COVID. They're responsible for making sure that that patient is tracked and that anybody that they may have exposed is also monitored. So many public health departments are using Emocha to monitor patients with COVID or their contacts. So that's how we help public health departments. I would say that the scope of this one is so massive that I'd say that there's so many local. It's always a local problem. So it's different in New York than it is in Maryland. North Carolina is lagging behind and doing a great job in terms of flattening the curve. So it's different everywhere. Their perceived need. Although I'm glad that public health is in the spotlight right now. In some cases, I consider public health to be like the police. It's a measure of safety for certain things that we don't organize because they're so infrequent.
Thank you for that question. Sebastian, what do you see on the 6 to 12 month horizon? What are you looking at as the CEO of Omocha?
I'm looking at the opportunities in front of us and trying to assess whether they're short-term, middle-term, or long-term opportunities. I'm trying to dedicate time to the ones that are always going to be there for us, like our public health departments, right? Like that business is increasing, and they're small, tiny contracts, but they'll always stay with us because that's our market and we know it the best. There are new opportunities that came up, like addiction clinics, where the standard of change will evolve in a sustainable way. And then employers monitoring COVID, I cannot imagine that we're helpful beyond the next 6 to 12 months. But on the other hand, perhaps if we take care of the problem, their employee health departments will consider Emocha for other types of needs. So I'm trying to bring in sustainable business, and I'm trying to make some new friends who hopefully we can keep as friends past 12 months.
Got it. And just in closing thought here, what do you see, if you could kind of frame it for us, as some of the lasting impacts this pandemic is going to have on the healthcare industry at large, and specifically telemedicine, telehealth?
I think that it's obvious that telehealth will become normal and no longer something that's special and differentiated from actual care. It'll just be a way, a method. And that's generally speaking a very positive thing. I also think that hospitals will be in crisis in the next 12 months. I'm personally, I really think that healthcare is unique, and you can't make blanket statements about healthcare in the same way you could about airlines. If you ask me, I don't like government bailouts in general. Because they benefit the largest, and I think that the up and comings or the entrepreneurs are at a disadvantage for such situations. And I really don't know what's going to happen with hospitals, because I'm not going to say, yeah, let them fail. We have a ton of infrastructure in place there. We have really some great clinicians and equipment and infrastructure. On the other hand, it's got to change. It's too expensive in this country. It doesn't make any sense. And the reason it's so expensive is because it's so ridiculously regulated. So I'm in as much a fog in a lot of ways as other people. I think it's a moving target, and I think that the world would be a much better place when there's a vaccine and a solid treatment for this disease in particular. And I think the economy will roar back, and hopefully we will have learned something about how we deliver healthcare.
Mm-hmm. Well, yes, we all hope and pray for a cure, vaccine, and treatment as soon as possible. Sebastian, thank you so much for joining us today. Sebastian, you mentioned you're out there making new friends. Well, you always have a friend in the Adam Smith Society. So thanks so much for being with us today. Everyone, thanks for joining us. Tune in again next week, Thursday, same time, 1 p.m. Eastern. We'll hear from Steve Fleming. He's the U.S. head of restructuring at PwC. We'll share his insights from the front lines of the economic impacts of the coronavirus. So tune in again next week. You can check out our full programming, adamsmithsociety.com. Thank you so much again, Sebastian. Everyone have a great day, and I wish everyone continued safety and well-being. Thanks so much, everyone.
Thank you, Greg. Thanks, everybody.